So good morning, everyone.
Good morning.
How's everybody doing on this fine, chilly Sunday morning?
Good, you?
I'm here, other than I haven't had enough coffee yet, but I'm here.
Did you do it? It's over here.
Well, I mean, I've got coffee.
Oh,
I just haven't consumed enough yet.
good, good.
It's the wrong time of day for that. Or maybe the wrong environment. I don't know.
Well, we can't drink at 12 o'clock. Sunday.
No, you can't buy beer until 12 o'clock.
But we drank all ours last time. So.
Actually, is Cleveland County not included in that change? You can buy it not 10
Yeah.
o'clock now?
The brunch now, you can buy early.
Yeah, but it's 9 or 10 o'clock. You know,
Because everybody needs a beer with
because
brunch.
I need a Bloody Mary in the morning on Sunday. So, I'm going to talk about waveform capnography. It's likely to be a review for everyone, but that's okay. You know, reviews are good. So, what are you doing now? Everybody try to throw in little jokes here and there and make somebody laugh. I don't know. Yeah, baby shark. So, yeah, I can honestly say I've never seen even one of those.
Baby shark?
Yeah.
You a little bit before today's out.
Yeah, I don't.
That's all right. You got your email. You'll get a whole bunch of them.
I'll do you a solid. I'll just wait and send you to one of my 4-year-old doing it because that's cool.
Yeah, I'm deprived, I guess, or sheltered. What'd you say?
It's also 100 beats a minute, so it's perfect to do chest breath.
So I see them on Facebook, and I just keep scrolling. Just ignore them. Among everything else that I can create controversy out of. So today we'll understand why we use capnography. We'll understand the physiology, pathophysiology of respiration and ventilation. We'll just kind of review that because we talked about that yesterday as well. Define normal and abnormal end-tidal CO2 waveforms and values, and understand 4 major applications for end-tidal CO2 for both intubated and non-intubated applications. Why? Well, that's a better question, really. Why not? Why not waveform capnography? But why? Why do we do it? In your own words, just give me a brief.
It's a better.
Because you're an idiot if you don't. Because you're an idiot if you don't.
It's a better tool, in my opinion, than like your pulse ox. It's more accurate with respiration. You get a good CO2 reading. In my opinion, it's a better determination of how a patient's breathing than your regular diagnostic tool.
All right. So nobody said because they said so. Right.
No, usually they do.
Hey, I'll trade you for M&M's.
Okay.
Yeah, let's show them M&M's around here, brother.
All right. Let's see what I got.
This is working out.
Ooh, that was close.
I'm sure you owe me one from yesterday.
Oh, here.
I got it. I got you covered, man.
So, uses for end-tidal CO2 waveform capnography and advanced airway management. Used to confirm tube placement. So, in comparison to an esophageal detection device, so end-tidal CO2 colorimetric changes we used to use solely before we transitioned away from capnography. And now, if you take it out of the cabinet, then I'm really surprised. But in a study comparing these, said there was no unrecognized misplaced intubations were found in patients where waveform capnography were used for continuous end-tidal CO2 monitoring. Failure to use end-tidal CO2 was associated with 23% unrecognized misplaced intubation rate. This came from a study in 2005. I'll give you another one that's a little bit closer to home. A teenager in Emerald Isle was injured in a skateboarding accident in his home. Said he was taken to Carteret, the medical center in Carteret County. And And he was intubated there, and he was being intubated at the hospital, and then he was being transferred by EMS agency to a higher level of care. At some point during the transfer, the tube was dislodged, and it was not recognized because they failed to provide the standard of care to use waveform capnography. In the in the civil complaint against the agency, the physician that sent it, the hospital, the individuals, everyone, pretty much everyone involved, including the respiratory therapist that was with them, said they alleged that they failed to provide standard of care, setting, verifying proper placement into tracheal tube, failure to recognize clear signs and symptoms of an esophageal intubation, failed to respond to these signs, attempted to falsify medical records, cover up their negligence, failed to use best judgment in treatment, said failed to use reasonable care and diligence in treatment of patient, and the application of their knowledge and skill in care of this patient. They failed to possess the required skills of learning to treat this patient, failed to practice within the standard of care for respiratory therapists, nurses, paramedics, physicians, and thereof. That's a lot of people. It's a lot of money. Which money is not nearly. I think it was since Drew Hughes ended up being on life support, brain dead. Did die.
Was it? So if it was, did he get intubated improperly by the hospital, or was it because the paramedics were intubated? Sure.
My understanding is that they, when they moved the patient, or at some point during movement and transport, the tube was dislodged.
You talking about Drew?
Yeah,
that's correct.
And waveform capnography was available, standard. You know, it is a application that's available. It just wasn't used by the organization. Needless to say, this pushed a huge push on our part, not just by providers in general, but by Drew Hughes' family, using the money to start a foundation in order to provide waveform capnography education in the state of North Carolina and establish a mandate from the North Carolina Office of EMS to use waveform capnography as a standard of care, so this doesn't happen to anybody else's child. Unfortunate that it takes something that's like that. I'm sure it's not an isolated incident. This is the one that came close to home. And this happened, say it's 26, like 2012. I can't remember the exact year this happened. So it's not been terribly long ago. And
I'm surprised if they went to the trouble of sending a respiratory therapist with them, if they didn't use it. That's probably the most surprising thing.
Now, was this a county agency, or was this one of those hospital agencies?
It was a
That's what I mean,
hospital
it's a
truck.
critical care service.
I want to say it was a county service, but I'm not 100% on that. Are you? Because there's two instances. One was a county service and one was a private service. Two instances that happened at the coast.
Drew was the hospital.
Okay, Drew was the hospital service. Okay.
That's probably why there was a respiratory therapist on board then. County agencies, I mean, at least around here, we don't.
You wouldn't have that. Yeah.
A little substandard too.
That's right.
So I can't because there was two instances that happened at the coast. Drew's was probably the biggest that pushed us in that direction, but another instance happened similarly, unfortunately. All in the course of about 18 months, two instances. So I guess the question is, why not? You're right. You know, we have the ability to do it. You know, I understand. I mean, even on patients where we use side string capnography, some administrators gripe because, oh, those cannulas cost $7, so the other ones are $4. Okay, who gives a rat's?
Ask.
Yeah.
Now, we did live that down.
Hmm?
They gave them to us and said, here,
Don't use them.
right.
That's a guaranteed way I'm gonna use them. All of them that day.
I usually do. I usually go through 5 of them this year.
Why would you think that, sir?
So, but the whole point is, it's a tool that we have to help aid in our treatment. Why not use it? If you give me a tool, I'm going to use it. But coming back to it being a hospital system and not using capnography, we don't we have, inside the hospital, unless you're, the patient's on a ventilator, unless it's on a unit, they don't have capnography. Patients on a ventilator in the ER, there's no way for capnography on them.
There is an RER.
There is a Murphy.
Yeah.
Or sorry, Western Carolina Erlanger.
Yeah, whatever it is.
Yeah, whatever it is.
today. Unless it's on a mechanical ventilator going to a unit, it does not. They don't have waveform capnography, which is, I think let me correct that.
Typically.
Typically, unless there's one physician working that demands it. There's one physician working that will absolutely demand it, and good for him. Granted, he's the medical director of the EMS service and knows what it's used for. So the other ones just don't have a clue. So you can use it for verification of tube placement. What's this mean to you?
Uh-oh.
Yeah,
Okay, let's be honest. We're going to look at it and we're going to go, damn.
You're like, now I got to work. So there's absolutely no better way to confirm tube placement so than waveform capnography. End of story, period. Because no waveform equals no tube. You can, we used to look at pulse oximetry as an example of oxygenation, and we'll get into the comparisons of those in a minute, but instantaneous feedback, and that's always the biggest thing I tried to when we pushed the launch inside the hospital to start using capnography on codes. This is why instantaneous feedback of what you're getting of your not just of your chest compressions, but of your ventilation and your oxygenation.
Question.
Yes.
Nurses, are they trained to understand capnography, waveform, and other things?
No.
That's not in their scope.
It must be. I'm going to
They-
disagree just because RER
They
is
are.
particularly invested in the capnography.
So when I say
it
they're,
depends on which hospital you're. I'm going to defend the nurses of my hospital because I know that's not.
But-
Well, I mean, in their schooling.
No,
what they
they're
call.
They
not
take
in-
it 2 days.
not in initial education.
Okay, that's fine.
In the hospital, yes,
Yeah.
because I provided education to so far about 250 nurses, specifically within the ERs, and then moving. Now take it back. Our PACU nurses are trained in it because they deal with it because patients come out of the OR.
Yeah.
They have capnography on, but nowhere else where the ER nurses, code team nurses have been trained now. Our procedural nurses are getting trained. Even in the cath lab, we didn't use capnography until about 6 months ago. So, which is why, we're sedating people to the point of not breathing at times, relying on, pulse oximetry as that indicator of how well they're breathing. You're like, well, they're 85 because I've been apneic for, about 90 seconds now. Oh well. My bad.
Everything to make capnography a basic skill. It seems way more reliable than pulse ox.
Yeah, that probably is a motivating factor because we're only going to use it on certain patients. In some applications. But I don't know the answer to that because there is a clinical judgment criteria that's in there, and I don't know what the new guidelines for the new basic education is going to be because apparently now it is being increased to 240 hours. That's a lot for an EMT basic.
Wow.
And
Class.
they recently got CPAP.
Yeah.
At least in North Carolina.
So-
That's something.
So I'm not going to say it's not possible, but I don't know I don't know when that would be. Just think about some of the basics you work with is what I'm thinking. not saying that's not possible, but cost factor would be a driving force out of that too. I don't think it'd be mandated a standard of care for a basic, just because you're going to blanket these organizations that do. Now, other states, yeah, it probably could be mandated because they can innovate in other states.
Well, I'm not thinking, I'm thinking like you have mobile SPO2. I would like to have
maybe. I don't know. So
Work with the right partner, just do it and say yes.
so
You're not gonna have each county paramedic.
respiration and ventilation and oxygenation are really, really different concepts. And we talked about it a little bit yesterday, what respiration and ventilation are comparatively. So kind of go over a few things today. I don't want to get real depth into the respiration versus oxygenation and ventilation today because we talked about it yesterday. Capnography is a window into the patient's ventilatory status. What's going on up top? What do you see? Looks like normal breathing to you? Okay. They're retaining CO2. Is this patient breathing fast? They breathing slow? They breathing normal? Okay. They're breathing slow. What about down at the bottom? Okay. They're tachypnic. You kind of said they're not as retaining as much, but they're breathing really fast. And you see they're getting quicker and quicker and blowing off more and more CO2 as we continue on. Yeah, probably. And I know I beat this one to death. It's what intubation method is most reliable. We talked about that, right? Oxygenation, ventilation. Somebody give me a quick difference between oxygenation and ventilation.
Oxygenation is gas exchange, ventilation is movement of air in and out.
There you go. Want more candy?
Yes, you want to
Twix. Can I have Twix for him?
No, Carol.
I said first.
So
I'm hungry.
you're hungry. Oh goodness.
Oh!
Be a fight back there. So capnography versus pulse oximetry. This is the most remarkable kind of orientation I get to folks is which device is used. Capnography passes an infrared light through a gas sample from exhaled gas, setting the pace so that CO2 absorbs infrared light. Both side stream and mainstream capnography is measured this way. Pulse oximetry clips onto the finger or the earlobe, forehead, and passes infrared light through the body to determine what part of oxygen-rich or oxygen-poor hemoglobin are present. So capnography end-tidal CO2 measures the carbon dioxide in the exhaled air, also known as end-tidal CO2. It measures ventilation, where pulse oximetry measures oxygenation. Capnography reflects breath-to-breath ventilation, where SpO2 reflects oxygenation and detects hypoxia. How long does it take for hypoxia to illustrate itself? Okay. Okay. I'll show you a video here in just a minute.
Are you saying
Like on your pulse oximetry?
oh, it takes a minute?
Okay, it takes a minute.
I mean, because you're going to say that.
And it depends. You're right. It does depend on your person, your health status of your person as well.
When I notice or when
That might be a difference. Oh, whoops, look what happened.
End-tidal CO2 detects hypo or hyperventilation immediately. Pulse oximetry can take time to detect problems. End-tidal CO2 does not appear normal if the patient is not breathing because no waveform, no breathing, unless it's disconnected. But that's a whole other animal. May appear normal, even if it's the patient's not breathing for SpO2. And CO2, end-tidal CO2 is not affected by supplemental oxygen. That's a accurate assessment. Not saying we shouldn't use pulse oximetry. It is part of that totality of the view of your patient, right? It's still a tool. So this video, I'll let it explain itself. It just compares pulse oximetry and end-tidal CO2, but it's a healthy patient. It's put together by a dentist, kind of that does procedural sedation.
We're going to demonstrate the difference between pulse oximetry and capnography with regards to how quickly each can detect a problem with our patient's breathing. We have our volunteer Becky hooked up to our monitors. As you can see, our pulse oximeter, which is attached to our fingertip, reads on the monitor anywhere from 98 to 99% at room oxygen. And our capnograph, which is detected through our nasal cannula, reads anywhere from 36 to 46 with a prototypical top hat appearance of the graph. We're going to have Becky hold her breath and see how long it takes each monitor to detect that she has stopped breathing. 3, 2, 1, go. Here we are at 10 seconds. Looks like we've lost our graph on the capnograph. And here we are at 20 seconds. The capnograph is alerting us that she has stopped breathing. And the pulse ox still remains at 99%. Now we're going to see how long it takes for the pulse ox to tell us that she has stopped breathing. Here we are at 40 seconds and still no change in the percentage of oxygen. Here we are at a minute 40 and our pulse ox is starting to go down. Yep. Still above 90.
Yeah, that's true.
Here we are at 2 minutes.
She's still wow.
Healthy.
She ain't no damn well every day.
She's my kind of woman.
Oh my god.
Ain't got no sense.
Here we are. About 2 minutes, 15 seconds for it to go below 90.
So she had to
Really,
start
the capnograph was
2
much
minutes and
quicker
15 seconds.
in detecting that Becky had stopped breathing, which is why it is now featured on newer state-of-the-art sedation monitors so that we can ensure our patient safety during sedation.
So I kind of utilize that because there's no real good, well, we can bring in capnography and I can't get anybody to really hold the breath for 2 minutes. I can't do it. I can't tell you that much. So now in most instances, our patients healthy enough and their pulse oximetry gonna, are they gonna be able to hold their breath like that for most people if we demonstrate it? She's obviously healthy, so obviously has practiced doing that. So no pun intended, but. So the physiology of oxygenation in relation to a capnogram waveform. So oxygen comes into the blood, right? So as their oxygen moves across the membrane, attaches to the red blood cells, goes into the capillaries, circulation. So it goes to the tissues. Metabolism takes place. Oxygen transfers to the cells. Carbon dioxide comes off. Carbon dioxide moves back into the lungs, the vasculature, and this is where our waveform capnography actually takes place. So you see oxygen leaving, as you see the exhalation, so the plateau and back to the inhalation. So exhalation, plateau, inhalation. Factors that affect end-tidal CO2, increased muscular activity. So as far as increasing it, increased cardiac output during resuscitation, effective drug therapy for patients with bronchospasms, hypoventilation. So factors that can decrease end-tidal CO2, decrease muscular activity, decrease cardiac output, so especially during resuscitation, bronchospasms, hyperventilation. I'll give you another one. If you have a patient with a pulmonary embolism, which I mean is still decreased cardiac output in an instance, but you're really decreasing the gas exchange taking place. So pulmonary embolism, you're going to have a decrease in the end-tidal CO2, but you're going to have a normal-looking waveform because there's no obstruction. You're still having the air. The patient's still breathing. They're just not having any gas exchange take place, in whatever area that the embolism is affecting.
So you're going to see your numbers, but not your waveform.
You'll see your
Depends on how big it is.
You'll see your amplitude of your waveform drop because that's based on your numbers, but you're not going to see a change in the structure of the waveform like we see with bronchoconstriction, what we see with someone who's being sedated. You're not going to see the actual structure. You're going to see a normal waveform, just the amplitude is dropped because your capnography your end-tidal value is going to be, half. Say if you have a pulmonary embolism on the right pulmonary artery, then you're not going to see that change take place because there's no gas exchange take place, or your right pulmonary.
But if you had a really big saddle or something, you really see a difference then?
Not
a really big one, or no?
You'll see a difference in the numbers, but not in the waveform itself, because there's no obstruction of the gas going in and out.
Okay.
There's obstruction of offloading of oxygen into the bloodstream. So when you look at the waveform, where the oxygen can take place and gas exchange can take place into the lungs, that's happening on both sides. But if you have a pulmonary embolism that's completely occluding the right, then the gas exchange is only taking place in half. So your waveform will be essentially half the size, but it's still going to be a normal waveform because you're still having complete air filling that lung, just no gas exchange taking place because there's no perfusion to the capillary beds. So a little bit of terminology. So a capnogram is the actual real-time recorded waveform. That is the image itself. So the capnograph is the waveform plus the numerical value. And capnometry is the numerical value by itself. So together, capnography is the value and the waveform. The gram is just the image itself. And so we take it both in together as a whole measurement between them. Just kind of, if you see, just kind of explanation, if you see the one referred to as the other. I know it seems kind of nitpicky, but so end-tidal CO2 is the measurement of exhaled CO2 in each breath. Normal range, what? 35 to 45. That's our target range, what we're looking for. A normal waveform is beautiful, and it looks like this, maybe. Okay, it doesn't look like that.
You can only go up from here.
Yeah, you can only go up from here. We can only... All right. So your A is your end of inspiration. So your B is beginning of exhalation. C is C to D is the end, the alveolar plateau, and D is the end of exhalation. And so D and the D point to E is the beginning of a new breath, and the new breath as a whole is a downward stroke. Beautiful, normal waveform. This is what we want to see, right? It's beautiful. Hypoventilation versus hyperventilation. Hypoventilation, you just have a longer fatter waveform, so there may be more amplitude on it. It may not be. It just depends on what your patient status is. Hyperventilation, lower amplitude, shorter, skinnier waveform. So 4 main uses. Monitoring the severity of asthma patients, monitoring the patients with head injury. Oh, why? What are we looking for with a patient with head injury? Okay. Increase in ICP. What are we going to use capnography for?
Irregular respiration.
Okay, irregular respirations, and we're going to target.
Are you still talking?
Yeah.
Sorry.
Sorry, I'm not awake yet.
For a second.
So
Irregular respirations, you're still gonna have. No, you're not.
Talk to her.
all right, so
Stop talking to her. God.
if we have a patient that's got a head injury, and we have that we intubate this patient, and we're going to control their respirations, what are we going to use capnography for in that process?
Looking for. I don't know if you'll see it on like chain stokes and biopsy respiration, things like that.
Well, you would, but where I was going with that is, if we're going to control the patient's respiration, it's got a head injury, our goal is to reduce intracranial pressure. We used to call this just blanket hyperventilation. Hyperventilate all patients with head injuries to reduce herniation. Well, we're causing more problems with that, so we're having selective hyperventilation, and we're targeting a end-tidal CO2 range of 30 to 35 millimeters of mercury for patients with head injuries. Any lower than that, we're reducing. The thought was we were reducing swelling, but we're actually reducing perfusion as well in the brain. So we want to bring that end-tidal CO2 down a little bit to prevent that increase in intracranial pressure, but we don't want to reduce it so low. So that's all I was kind of getting at, is with a patient with a head injury, we're targeting their ventilations to 30 to 35 millimeters of mercury. Cardiac arrest. I kind of beat this one to death. Why are we using for cardiac arrest? What are you going to see?
You're going to see a spike in capnography.
Absolutely. You're going to see a sudden increase in your capnography for spontaneous circulation. So if you're doing resuscitation and you have a end-tidal CO2 of 12 and all of a sudden it's 30, what the hell's going on here?
Also help with chest compression.
Yeah, absolutely. Help you determine how well your chest compressions are being done. If you're getting the end-tidal CO2 at 24, and you're getting good quality chest compressions. That's awesome. Tube confirmation. I'm not even going to go there. We beat that one to death. So side stream technology is an indirect measurement of a non-intubated patient. How many use side stream on a regular basis? Okay. What kind of patients do you use it on? Just
all of them.
Any respiratory patients? Seizure patients? Okay. Asthma? So
Anytime you give like a narcotic, morphine.
absolutely. I like that. Who wants candy? I don't know.
Thanks.
She didn't even pay attention. She's going to quit.
Hey!
I'm doing my best to feed the endocrinologist this week.
You can't do it for pretty much anybody other other things.
What?
I'm hungry.
Should have gotten breakfast on the way here.
I had a bagel and I had a whole bag of
Man.
greens.
So mainstream capnography is a measure for an end-tidal CO2 with an intubated patient. I'm sure everybody uses mainstream capnography on all your intubated patients, right? Anybody not do that? Okay. Asthmatic waveforms, said the ambiguous shark fin appearance. Wow. So these patients are having a problem with what?
Getting air out.
Getting air out. So we're seeing their exhalation plateau is extended. It's sloped because they're having that exhalation period is extended, so having trouble getting that out. So we see this ubiquitous shark fin appearance. Always probably the best description I've ever heard of that. So of severity of asthma attacks and end-tidal CO2. So you'll see the top being a mild, early forms of a asthmatic attack. You see moderate on the bottom, where you see that exhalation being extended even further, those respirations slowing down even more. And the severe. Yep, that is bad.
Yeah.
So what do you think this is? What do you think's going on with this patient here? Why is this? What does this tell you right here? They're tired. So what do you need to do?
Fix it.
Something quick.
Yeah, we need to do something quick at this point. This patient who looks tired, they have this type of shark fin appearance, so they are headed for respiratory arrest, and they're not going to be able to maintain compensate too much longer. So you absolutely need to get moving. Head injury patients, and kind of where I mentioned this a little earlier. Carbon dioxide dilates the cerebral blood vessels. So it increases the volume of blood in the intracranial vault, which actually causes an increase in intracranial pressure. So recognizing head injury patients and titrating their CO2 levels to 30 to 35 can help relieve the untoward effects of this increased intracranial pressure, but we don't want to vasoconstrict it too much. So titration is not hyperventilation. It is basically getting these intubated patients by using to a selective range. We're not completely hyperventilating them. We're just trying to blow a little bit of that CO2 off, keeping them between 30 and 35. End-tidal CO2 cardiac arrest. The intubated patient, capnography is a direct correlation to the cardiac output. So, like I said, increase in CPR could be an early indication of ROSC. You have continued capnography with high-quality chest compressions at less than 10 is an indication that this patient will not survive. How many of y'all use this as an indication when you're terminating resuscitative efforts? Good. That's a huge. I'll be like the first one. I'm like, nope, we're gonna call this. I haven't seen the patient yet. We're gonna call this. That's kind of a joke.
You must be a
It's kind of a joke, but depends on where you are. How long it's taking you to get there. Walk in and this patient's going to require us to cut the house open. I'm like, no, not happening today. Survivors to discharge typically during resuscitation have capnography with high quality CPR of greater than 30. Those that survive to somewhere in the middle, kind of mixed results. Just depends on what happens, whether it be survival to discharge or survival to event farm. We might get ROSC, but they might not ever leave the hospital. Verification of tube placement, again, beat this one to death. So don't have a waveform, don't have a tube. So. Some overzealous paramedic yakking his jaws, not paying attention. Nobody would
runs in wants to help.
Nobody would do that, right?
Supervisor runs in wants to help.
Yeah.
Let me get this too.
We had a director like that.
Gee. So I remember, to tell you how much people don't understand, like physicians don't understand waveform capnography. I have a patient we had a cardiac arrest, we got ROSC, a huge pulmonary embolism because we have a waveform and it's very minimal. Patients blew from the nipple line out. Typical pulmonary, typical PE. we got Ross. This was probably the hardest, to this date, the hardest intubation of my life. And we roll into the ER at the former Murphy Medical Center. And the physician goes, "This tube's not in. She's blue. Rip."
I remember this. Oh my God.
I'm like, we had a waveform. They saw the waveform. And so that Ross went to shit because he couldn't get her reintubated. Well, I say I got back. He did 9 minutes later.
Oh, that's good.
So she obviously did not make it. Not that she was going to make it for that massive PE anyways, but there was a chance before you absolutely took every bit of airway that she had away. And I'm like, I couldn't even get out of my mouth. I said, "You have a waveform." "Nope, tube's not in." But F it, I'm out.
Not here.
Sign my paper. Sign my paper. Sign my damn paper quick.
So the nurses are sitting there looking at her like, "Can't believe you just did that." I was like, "Yeah, I can. Thanks." That was one of about 3 incidences before that physician was not invited to come back and work anymore.
Wait, is it 1 of 3?
Yeah, one of 3 instances. Yeah. No. She understood. No, he went straight from there. Went to Union for about for a little while, and then got kicked out of Union. So when it comes down to, if they don't understand what it is, they're not going to pay attention. They don't. I mean, the tube's in. If you have an internal CO2, it's not in the esophagus. There is no CO2 coming from the esophagus. You will not have a waveform, and you will not have CO2 if the tube is misplaced. Period.
The belly's full of beer.
You're not going to have a waveform associated with that CO2. So, what are some of the main characteristics of a capnogram for a patient with COPD or asthma? Yeah, shark fin. You're seeing that.
Candy.
You gotta have to speak up.
Yeah.
M&M's.
She said candy. Hello.
She been waiting for a question she can answer the entire
Oh yeah, an epilepsy. You know what?
I'm done.
Let me just go to the car and get my fucking helmet.
Oh
And
my
shit,
God.
'cause
Thank you for taking one.
I got the.
You know what?
I'm
I'm gonna give this somebody else to hand out.
There you go.
I'm done.
I think you need
That's
some more
because he
time
thought
at
your ass
softball.
was asleep. Now wake up and pay attention.
I had to quit I had to quit softball because I got too competitive, and
Are you sure that's
People probably gonna,
yeah, I didn't pay
Yes,
it. I was an outfielder, so I didn't have to worry about that kind of stuff. But I get too competitive, and I hurt.
Stop inviting him. That's why.
Yeah, I hurt somebody in church league softball, and I'm like, you know what? Maybe I ought to.
Yeah, pray on that.
Maybe I ought to stop.
Now, no kid, that's
Woo!
and no kid in Alamance, we've had more fights at church league softball than anything else.
So like, you ran over me, so you don't block the base.
Thank God.
It's like, don't block the base. Don't want to get run over. Don't block the base. That was my last church league softball game.
He's like, bless you.
Asshole.
Something like that. I felt bad. Kinda. Don't
You
block.
spiked me. Well, at least I didn't do prenatal.
Doug Colbert.
Slide in the second.
Oh. So,
Yes. That's kind of,
how does one determine the severity of an asthma attack using waveform capnography? I'm sorry. Yeah, you're gonna what it looks like. You're gonna be your numbers. What's the waveform look like itself? Shark finish. It's gonna be big, tall, long. Megalodon. So what level should you maintain your CO2 at for your patient with a head injury? 30 to 35. And tell me about some ways to use capnography and total CO2 during CPR.
It's less than 10.
If less than 10, there's a good chance they're not going to make it.
Tube placement and return to rotation.
Tube placement, return of ROSC. Sounds great.
That's true. You can use it for good CPR.
Absolutely, you can use it to determine how well your CPR is going. I like it. Somebody else can hand out the candy. I'm not throwing anymore.
Feels funny.
What?
Come on.
Slightly rip the whole bag rather
This
than
isn't
the
church,
air.
so we're telling you can.
Seems like it easy.
Well, you really hit
Here you go.
Oh my word. Oh my word.
G.
I think that nobody
So, troubleshooting inadequate seal around the cuff, ET tube cuff. So you see a waveform distort. So before you panic that you've lost your waveform, remember, you still have capnometry. You still have CO2. You still have some type of waveform. It just looks like garbage. So what do we want to do for this patient? Do what?
Fix them.
Fix them. But in this type of waveform, you look at your air is leaking around the cuff of your tube.
make sure your cuffs and white.
There you go. Make sure your cuff's inflated all the way. Increase your inflate your cuff. So an obstructed tube may have erratic CO2 waveform with very irregular pattern. So again, you're going to have CO2, but you may have an obstruction within your tube causing your waveform to be erratic. What can be an obstruction in your waveform or in your tube? Blood. Yeah, absolutely. Secretion.
You're a bad innovator.
Could be bad innovator. Yeah, traumatic innovation. The other thing, sometimes those secretions end up saturating your sample chamber as well. Sometimes you'll have to actually swap out your adapter. So dependent on your device. Said patient's rebreathing. Said a patient capnogram that doesn't touch the baseline is an indicative of patient who's rebreathing CO2, insufficient respiratory effort. So you see the waveform does not actually reach back to baseline. So they're exhaling, inhaling, but again, they're not even done inhaling before they're exhaling again. So they're rebreathing in this instance.
Would that be like shallow respiration?
Be shallow respirations. It could be a patient who's just taking in, like breathing in and not exhaling completely or not inhaling deep enough, and they're not necessarily tachypnic, but they're just breathing so light. Or look at your patient who's intubated. You can be doing this to your patient if they're intubated, and especially if they're not sedated. So they have an insufficient inspiratory or expiratory effort. So we can fix that, right? Yeah. If your patient's conscious, can you fix this? Yeah. How would you fix this if your patient's conscious? Coaching them, absolutely.
Breathe better, damn it.
Do what?
Breathe better, damn it. Give them a hold their breath for a little bit.
Just paralyze and intubate them. That'll fix it. We can control this. No, I didn't say that. I'm not advocating that. I said it.
I heard you did.
Yeah.
I reckon everybody told this.
Whatever. Whatever. What's going on with this patient? Yeah. Very slow respiration. So they've got hypoventilation. What about this? Yep, rebreathing because it's not touching the baseline, right? Yep, esophageal tube. Do 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 do. Yep, shark fin wave. Like that. Normal?
Everybody's been eating those glasses. Wait, that's not normal. Yeah, there's something wrong.
Yeah, that's it. Normal? Yeah, normal. Yeah, they're trying to. What happens when we see a QRA cleft? What is going on with your patient? Listen. Yeah, your paralytics are wearing off, so you need to do what? Hit him in the head. Yeah. So, let me throw an ethical or just hypothetical scenario out to you. So, how many of y'all RSI here? Your patient is waking up out of this. Do you re-paralyze them, or do you just move on to sedation? Okay.
We just recently, 4 months ago, our director allowed us to give up to 500 micrograms of fentanyl, specifically for sedation, along with Versed, up to 500, just to make sure that they're not.
I think that's because sedation is much more humane instance than running to pay services that will just blanket, oh, they're waking up. I'm just going to re-paralyze them.
It's just wrong.
You're right. That's just wrong. Having been paralyzed and intubated, that's just wrong. I remember it. So that's just that's when I had all my surgery. I had a bleed, and they paralyzed me and intubated me in the ER.
You remember it?
Yeah. Yeah. Because they couldn't sedate me ahead of time because I was throwing up blood.
Oh.
So I was sitting up, so back of the stretcher, sitting up, and so the anesthesiologist paralyzed me, intubated me sitting up in the bed, and I remember me stopping breathing, like I couldn't move.
I mean, it's terrible, but that's kind of cool.
Yeah.
Yeah.
It was a terrible panicky feeling. It didn't last for very long because they gave me other meds, but
After those few seconds, and you could feel the two go down.
I could feel everything, and I couldn't move was the scariest part. Like, because I could feel that I wasn't moving. I couldn't move.
How many years ago was it?
2014.
So 2014, you got a gift that'll stay with you forever.
You have no idea.
Bad damn feeling.
Yeah, you have no idea. So I'll
I mean, imagine the perspective though in teaching other paramedics. That's actually kind of
I'll give you another perspective out of it. So it gave me a much greater respect for RSI because they intubated me with succinylcholine, and turns out I was hyperkalemic, and they didn't know that when they did it. So I was trying to figure out. I got after had that second surgery on October 31st, Halloween day, and I had night sweats. Like, okay, a week after, it was weird. I mean, all the way until like February. When I mean night sweats, I would wake up, have to like peel the sheets off the bed, put a towel down. That's how much I was like waking up in the middle of the night, completely drenched. Like, what is going on? So I start talking to my friend who's a CRNA, and I pull my chart, my record, and I'm like, holy crap. They didn't just paralyze me, intubated me. I had arrhythmias. I had all kinds of stuff go on in that surgery I didn't know about. And so I start pulling everything else that's related to that. It was like, oh, it's hyperkalemic, and they RSI'd me. And I just figured out the metabolic effects don't just last for days or weeks. They last for months, trying to for your body to get back to normal. And all that was because the succinylcholine interaction with my body when I was hyperkalemic. And so the metabolic effects affected me for months. Gave me a much greater perspective on intubating RSI patients. So was really annoying for a while because this wasn't just every once in a while. Every single night I was having to like put towels down and sleep on. So it's crazy. So it took me a while to figure it out as to what the heck was going on. But 7 weeks out of work give you plenty of time to do that. So
So what do you do for that patient?
This patient, sorry, squirrel, sedate. Sedate. This patient is usually after you have performed an induction, so where basically they're starting to come out of the paralysis or sedation, and they just need more Versed, more fentanyl, whatever your policy is for sedation. So.
Okay, let's chase the squirrel again. Did you go back and ask him why the hell they didn't do anything for you other than just
No, I didn't.
So you're a nice guy.
Yeah, I work with these guys now too.
Oh hell.
You just kind of give them the look sometimes. Oh,
Every time he pisses you off, oh yeah, you remember that one time?
Yeah, I work with these guys now too. I mean, that's the scary part.
At least it was a purposeful
Lisa,
sterilization, not like the one in Vanderbilt.
yeah, that's a good point. That brings up a whole slew of issues. Those of y'all, anybody not know about that? So a patient, I guess it was last year, or maybe it was in 2017. It just came out in the last 3 or 4 months. Patient at Vanderbilt is on the floor. They go down for a CT. He's got a lot of anxiety. So before they leave the floor, they have some Versed ordered. They couldn't find the Versed in the Omnicell, so they override it. Pull the first thing, give patient, say push the meds in the patient, which I'm not real sure how, because they gave VEC. VEC has to be what? Has to be, you have to reconstitute. You have to reconstitute it. So how this didn't like key off in their head that, oh, this doesn't seem like Versed. Oh well, I'm going to keep mixing it up. And so they gave VEC and sent this patient down unmonitored to a CT. What do you think happened to this patient? Yeah, put him in a CT. 30 minutes later, they find the patient not breathing.
You never moved the whole thing.
Yeah, the CT went great. Huh? So how this came about was if you have a death out of in the hospital for a problem, you're supposed to disclose that immediately. This came about during a Medicare audit, and they had already taken plans to. Their only saving grace is they'd already taken steps to implement corrective procedures and all that stuff, but they still didn't disclose it. I mean, there's all kinds of problems here. One, how a patient leaving the floor, how they had a VEC and an Omnicell that somebody could have access to. They shouldn't have it there, like on a regular, even on an ICU floor. It needs to be separated. First, second off, we're reconstituting it. I wonder, man, this person's awful weird. I gotta fix this up. I don't know.
Didn't even read the label either.
So yeah, then we're coming down back to the whole your rights and medications. You're like, well, I don't.
You think that you'd notice this substance?
You would think you notice that difference.
Let's not all pretend every single time. There's certain. You're like, oh, green cat, go.
Yeah.
It happens.
But
the Dennis Quaid thing that they gave one of his twins one drug that was like so 1,000, the other one was like 10,000. It's just like a slightly different color blue.
Yep.
It was like you still read the bottle.
Yeah, you still should read the bottle. So, needless to say, it was a poor outcome for that patient.
Well, they fixed his anxiety. I know.
Yeah, they fixed their anxiety. They didn't have any more anxiety about CTs ever. So, anyways.
Did they not have him hooked up to the monitor and stuff?
No, they didn't. That's the other catch is they weren't monitoring the patient during the CT at all. So that even if you gave the Versed, you still should be monitoring the patient. Yeah. Like I give that patient a ticket to ride, send them downstairs to the transporter, they weren't breathing the whole time. There are failures on multiple levels there. So, all right, everybody, let's take 10 minutes, and we will try to remind me at close to 11:30 before we get to 11:30 that we need to stop. so that we can go
I
in.
got you, man.
Stop.
If everybody think that's okay, soon enough. If I'm still talking, just get up and walk out. I don't care.
I have no qualms about telling you to hush the hell up.
So, basic overview of how to interpret 12 lead EKGs and treat a cardiac patient. Is this something that we review a lot? Do you all review 12 leads a lot?
Not like we should.
Like an education in service?
We just did STEMI and mimicry.
Okay.
Well,
All right.
I took that class. I don't know about the rest of
So
I tried. I
that
did that watch her one day.
Let me introduce you to James, the model employee.
Training center.
wow. So purpose: we're going to provide pre-hospital clinicians with tools necessary to identify the anatomy and physiology of the heart, interpret 12 lead EKGs, so localize and treat AMIs, as well as recognize impostures and potential complications related to coronary care. Glenn, did you hear me at 11:30? We're going to
Appropriate.
Okay.
Chinese.
Chinese cat for everyone.
Oh.
So basic A&P, the heart's a muscular pump. It's about the size of the fist. So its primary function is to pump oxygenated blood to the rest of the body. 4 chambers, the right and left atria, right and left ventricles. The septum is a thin muscular wall that separates the right and left sides. Remind me when I come back from lunch to really break down the anatomy portion with some dissecting pictures. I'll try to remember to do that. Somebody remind me though. Dissected picture. You can write it on the board right here.
What are you wanting?
I have the
same part.
I have the dissection lab on the computer. The septum is a thin muscular wall that separates the right and left sides of the heart, normal individuals. So each contraction occurs in response to an electrical impulse that starts in the upper portion of the heart. Where does that electrical impulse start? Review here. SA node, yay. Somebody else is responsible for candy. Who's throwing that? Underhanded out. I was obviously messing that up.
Quit pitching on that girl.
Bloods move through a closed circuit of the body, so by the pumping mechanism of the heart, at least it's supposed to be closed circuit. So the heart contracts and pumps blood throughout the body in systole and relaxes and to allow filling during diastole. The heart is a muscle like itself, and in all other organs, the body requires oxygen to function. What is different about the heart than other organs of the body? Okay, it feeds itself with blood. Okay, that's not where I was going, but okay. What is different about the circulation for the heart versus other organs of the body? How is the circulation different? Where are the? Okay.
The veins are actually.
Well, the vein. That's the vessels. The vessels are on the outside. There you go. That's where I was going. Vessels are on the outside. There you go.
Man, I'm gonna be so high.
Oh God, I didn't even think about that. So I'm sitting back there feeding him sugar. Somebody, why didn't y'all be like, hey,
I'll take some
stop giving the ADD kid sugar. Oxygen-rich blood is circulated through the coronary arteries.
What? What's your point? No, the hell I did.
Damn it, Robin.
2 main arteries, the right coronary artery and the left main coronary artery. Both start at the aorta. These vessels branch off into smaller vessels along the surface of the heart. Maybe. So it's beautiful. You have the left main coronary artery. So you have your left circumflex branch that goes around the backside. Your left anterior descending comes down the front of the heart, and then your right coronary artery, the serves the right side and the posterior of the heart. In order to perform work, the heart needs oxygen. Both coronary arteries originate in the aorta along the surface of the heart. Blah, 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 click, click, click. I already talked about that. The left coronary artery divides into the LAD, so the left circumflex. So the right coronary artery branches and branches off the left coronary, provide numerous smaller branches which penetrate the heart muscle, supplying blood to the entire heart. So the majority of human hearts, coronary circulation follows a predictable pattern. I say majority because there are people that have different anatomy, and you see different things with transposed vessels. You also see transposition of the great vessels, but that doesn't necessarily affect the coronary blood flow. It's really remarkable when we look at these patients that have coronary abnormalities, because you expect to see a predictable pattern. And when you get to see someone with an abnormality in coronary blood flow and angiography, it's like, that doesn't look right. That's really cool. So you get to, it's a learning instance for me when I get to see that. So it's wild.
When people have flipped bodies,
yep.
Do they still typically have the right vessels, or are they flipped as well?
So everything like when they have the, you're talking about when everything's flipped.
Yeah.
Yeah. So everything looks a little bit different. The vessels still follow a predictable pattern. Well, I say that I had 3 weeks ago, had a patient that had that. To tell you how uncommon it is, the physician marked his 30 years doing this on New Year's. So we've known this for 30 years. He'd only seen 3 people with that. Wow. That was the 3rd person. So that's really uncommon. So this patient, it followed a predictable pattern, but you had to basically, picture everything backwards. So I'll see if I can find some angiography pictures of something like that too when we go to lunch. So the left main branches quickly into the LAD and the circumflex. Said it serves about 2/3 of the heart in most individuals. So the circumflex provides blood to the left side and the lateral portion and the posterior portion of the left ventricle. And the RCA supplies blood to the bottom of the inferior portion and the posterior portion of the left ventricle, and also the posterior portion of the septum. And sometimes you'll even see instances from the circumflex, depending on the person's anatomy. So come down if they're left dominant or right dominant system. You'll see these arteries branch all the way around and provide blood flow to the other side. So it's like in the right coronary artery, you'll see these look both plump and healthy. Sometimes you'll see people with left dominant systems that have really small RCAs, and the LADs will actually branch further down to the right side. Really kind of wild. The other thing you'll see is when we have patients who have had blockages, and you'll see them develop other branches to try to help perfuse the areas of the heart that have been deprived. So 55% of people, the RCA supplies the SA node, and 90% of individuals, the RCA supplies the AV node. So pretty much everyone with the AV node. The composite is responsible for AV blocks. So if you see patients with blocks develop, generally is responsible for something to do with the right coronary artery. The LAD supplies blood to the front and anterior portion of the heart, the left ventricle, so the anterior portion of the septum. LAD blockages can be very severe. So we see patients with EKG elevation. We'll talk about what areas. So we see patients with STEMIs that are affecting the LAD and the front of the heart very, very severe. Not that any RCA infarct isn't severe as well, but LAD, you see bundle branch blocks, acute MIs, congestive heart failure, because the LAD supplies so much blood to the heart. Why? If you have an infarct in the LAD, or if you have a blockage in the LAD that causes an infarct in the front portion of the heart, it affects a large portion of the left ventricle. So when we talk about heart failure, the heart's just weak, right? So it's not going to work as efficiently as it used to. So when that heart becomes weakened and the ejection fraction's reduced significantly, so these persons have chronic heart failure issues. Congestive heart failure, again, we talked about a little bit yesterday. AMIs and coronary artery disease, a most common cause of patients experiencing congestive heart failure. In 45% of people, the circumflex supplies the SA node with blood. In about 10% of individuals, it provides the AV node, and it's responsible for lateral and posterior MIs. So we talked about it briefly. SA node's the natural pacemaker of the heart. So the heartbeat starts here, spreads through a conduction network of fibers to the two atria, causing them to contract. The bundle branch, the bundle of His in the Purkinje system is an electrical system that finally passes to the ventricles, causing them to contract. Normally, the heartbeat can only reach the ventricles after it has passed through the AV node. So the AV node slows down the impulses so that the atria can contract, finishing and allowing the ventricles to fill completely. So then the AV node also prevents the lower chambers from beating too fast. So if the atria develops a fast rhythm, then it slows those beats down. What would be an indicate, or what would be the rhythm we're talking about here?
Say that again.
So the AV node slows down the electrical impulses, keeps the ventricles from contracting if the atria develop a arrhythmia. AFib, absolutely. So the atria are contracting too fast, so the AV node is slowing those impulses down to prevent them from getting through to the ventricles, so that we have that conduction delay. So EKG is merely a measure of electrical activity of the heart. It's primarily comprised of three parts: the P wave, which is in this beautiful diagram. So the QRS complex, so the electrical depolarization of the ventricle. And the T wave, which is the electrical repolarization of the ventricles, thus relaxation. So what is our P wave doing? That's what part of the heart contracting? Atria. QRS complex is ventricle contracting, and T wave is relaxing and letting us start the cycle all over again. So my great illustration. I'm up here fondling stuff in the air. So the P wave represents a positive or negative deflections, the atrial contraction and relaxation. PR interval is the distance between the P and the R wave. It should be consistent. Should be consistent. So for those AV blocks we'll talk about in a few minutes. QRS complex, the Q wave is the first negative deflection. It is present and normal in leads 1, AVL, V1, and V6. Significant or pathological Q waves are 1 box wide and at least or 1/3 the height of the R wave. If we have a significant or pathologic Q wave, what does that tell us? Yeah.
That they've had a heart attack in the past.
They've had a heart attack in the past. You want candy?
No.
Okay.
You can give it to Robin.
Feed the diabetic.
Feed.
Thanks.
We've been hurting on this. There's still more to go. The R wave is the first positive deflection, and the S wave is the next negative deflection. The ST segment is essentially on the isoelectric line. Said it slopes gently upward. So J point is placed where the ST segment is from the takeoff of the QRS complex. What is this right here? Why is this important? Yeah, note your ST elevation. You're looking for that J point, and you're looking for the ST elevation at that point. So that tells us we have a. So you have a scheme. So you have a ST elevated MI going on. Absolutely. T wave upright. All the T waves are always upright in leads 1, 2, V2, V6, and AVR is always negative, and leads 3, AVL, AVF, and V1 can be positive or negative. U waves are best seen in V3. Hello, hello, hello. Do you need me to mute you? You got it. So U waves are seen, usually the same polarity as a T wave. It is a sign of hypokalemia. Said QT interval is one complete ventricular cycle, so that is from the start of depolarization to the end of repolarization. Said none are less than half the preceding R to R interval. We'll talk about that here in just a few more minutes while I'm sitting here. We should have enough power to make it. I can't. The only reason I say that is I can't project and charge my computer at the same time. There you go. I got 21% left. It should be okay. So putting the anatomy together with the EKG, you've all probably seen this picture before, or an equivalent one of it. So your SA node and your internodal pathways, along with your AV junction, said your atrial depolarization. So that's your what? What wave is that? P wave. I heard it, kinda. That's your P wave. With your electrical junction moving down through your bundle of His, so it is your PR interval, said to your bundle branches and your Purkinje network. That's when we start ventricular depolarization. So it's our what? QRS complex. Yes. So as that electrical impulse finishes, depolarization finishes, and you have ventricular repolarization. So this is the QRS is the electrical impulse of the heart. It is not. Let me rephrase that. It does reflect what the heart's actually doing, but can you have this without a heartbeat? Yes.
It doesn't reflect the actual.
It doesn't reflect the actual mechanical function of the heart. Mechanical function of the heart actually follows this by a fraction of a second when you actually have a mechanical function. So when you see the atrial depolarization, your atria are actually contracting during your PR interval. So there's a fraction of a second delay. Because what's quicker? Is the electricity quicker or is the mechanical function quicker? Yeah, the electricity is quicker. Yeah, everything else has got to catch up. So
If you were monitoring the heart directly instead of through the chest, would it be close?
You mean like if we're looking at it through fluoroscopy, you're still going to see, and it's actually going to even appear more delayed when you're monitoring fluoroscopy because it's observing it, it's transmitting it, and then we're going to have to see it and interpret it. When you're monitoring it through an arterial line waveform, it's still a fraction of a second behind. So when you're looking at your QRS complex and your arterial waveform, the QRS complex is here and your arterial waveform is here. When you're looking at them on the same screen, they're just slightly offset. Yes, ma'am.
You guys pass this around. Check your email and check your phone number. If it is correct, please put a check mark by your name. If it is not correct, use this second page to put your corrections on there. Thank you.
You're very welcome.
If you're not on the list, write your stuff on the second page.
There you go. Involvements triangle. Yeah, I can't. Said you have lead 1. This is on your what type of EKG?
3 lead.
3-lead EKG. Lead 1 extending from your right arm to the left arm. Said lead 2 extends from your right arm to the left foot. And lead 3 extends from your left arm to the left foot.
Yeah.
That's fine.
Really. I'm here.
Change the socks, do some saline.
Little motion.
So change the socks, give him some saline.
Turkey sandwich.
Just don't forget the cat motor.
Turkey sandwich. Just don't.
Make sure you take his temperature because it's vital for this.
Oh, I need to report your GCS to the hospital.
I'm sorry, I don't understand.
Our hospital they sent out an email to us stressing that we report a GCS on every single hospital call. That alert and oriented is not good enough.
Yeah, I talked about that the other day. I'll tell you if they're unconscious. If I don't tell you they're unconscious, assume they're conscious. If they're intubated,
No, when we were supposed to start that stuff.
eventually. I don't care.
Okay. Anyways, I'm not even going to dignify that with a response.
You should come work with us for a little while. It's fun.
You know what?
We're hiring.
For a director.
We need a training officer.
And a director.
You're gonna stay in contact with them.
You know what's that? And you know,
There were a few that.
so anyways, back on topic. The said format of an EKG is very standard. A few exceptions, but generally you'll see this format in your EKG no matter what type of monitor you have, whether it be a Zoll, Philips, Vizio, etc.
Come in.
Not today, Tim. Okay.
Careful. So the 12 lead can provide a computer-generated interpretation. How many of y'all rely on that? Good. How many?
Actually, that number's higher than I would have thought they would have said for accuracy.
So that's an accurate number because
If it's an acute MI,
if it's acute MI, if it says possible, no.
Okay.
But if it says, you know,
Okay. I was gonna say that's like every single one.
but you also have to take into account artifact present.
lead placement.
You have to think about the quality of the EKG. I want to say that's 98% accurate at the time. That is based on an EKG that has good quality. Things that can affect your EKG qualities. What are they?
Hair, sweat. Skin prep.
Hair, skin, sweat, skin prep,
Lighting.
lights, truck lights, going down the road, vibration.
South Carolina Road.
What about that package of electrodes? How many of y'all have fresh electrodes ever shipped?
Pretty much. Everybody gets 12.
So that 12 pack or that gigantic pack of electrodes, those electrodes have gel on them, and after about 18 hours, that gel starts to dry out, and your quality of your electrical transmission is impaired based on that. So yeah, that can affect it too. So it's supposed to be stored in a sealed bag and all that stuff. How many people do that? Yeah. You're like, man, it'll be fine.
Well, sometimes they stay in a storeroom a year.
Well,
All
as long-
kinds of conditions.
But that's true. In order to attain specificity, the computer isn't absolutely sure. So an AMI is present. It will not say anything. No interpretation needed or data quality or whatever it may be. You are the primary interpreter. The computer is your backup. If you don't think it's a STEMI, but the computer says AMI suspected, I'm going to have to look at it real carefully and see what the heck's going
I'm
on.
gonna run a couple more.
How many of y'all getting a patient from the emergency department? It says AMI suspected, and you're like, where? You're looking at the 12 lead.
How many of you get an AMI that they tell you the hospital's an AMI and it's
Yeah. Remarkable how many of those are right, but it's also remarkable how many of those are wrong.
Or you go in telling them it's STEMI and then,
Better.
oh no, it's not STEMI.
Yeah. I'm like, well, I'm looking at this and I don't see it. I see a little bit of ST abnormality, but the machine called it an AMI. That's weird. Sure enough, bigger blockage bigger than hell.
Yeah.
So sometimes you have to trust the machine.
It's a good thing.
It's a tool.
No, it is. No, you're not listening. It's a good thing. Right here.
You
Notwithstanding.
and your
Am I?
Yeah.
Perfect 12 lead. Up at the top.
Suspect AMI.
No, acute STEMI MI.
But look good. You have blockage.
It said acute STEMI AMI. It said acute ST elevation myocardial infarction.
You're an ass.
But I say I'm slap the shit out of him.
Anyway, yes.
But
We did.
but that's a perfect example of trusting the machine versus be like, oh, it's wrong.
Tell me how long you waited to go see anybody after you started having chest pain there, Rob.
End of the shift.
Ended the shift, went home and showered and came back.
Well, you gotta be clean.
Model employee, right here. Model employee.
12
Be in a bus, go back to bed.
12 lead is very good at measuring intervals and durations. I'll give you a squirrel moment on that. I had a friend that worked with, same instance. He had discomfort. He said, he wouldn't call it chest pain. It was just discomfort.
Yeah, what one of these Elizabeth I'm coming.
Went home at the end of his shift, got ready to go out and mow lawns. Keeled over dead.
That changed quickly, didn't it?
Yeah.
Didn't it?
That worked out a whole lot better than his head, I'm sure.
Unfortunate. He got off shift. Was 50, 54, 55 years old.
She knew she was having a heart attack when she went home to take a shower. Yeah.
I'd been
You stubborn.
She's been having the heart attack. How much worse can it get?
When I was there,
Like 12 hours before I left.
That time is muscle things. Just a recommendation.
when
I
I
got a whole lot of heart. It'll be fine.
Robin, when I was there and having chest pain, my supervisor wouldn't let me leave the go.
Mine told me I wasn't going home.
Mine wouldn't let me leave to go to the doctor.
We don't have anybody to cover your shift. I'm sorry.
Yeah, I'm sorry. Can't have that right
work, right?
now.
Yeah.
I'll fire you tomorrow.
Yeah. I just want that. I promise.
Here's some Plavix. Here's some heparin. We'll get you there tomorrow.
But she has to we're dressed shit.
Yeah. So 12 lead's very good at measuring intervals and durations. So it's better at measuring the PR interval and the QRS width than one would expect. How many of you all tried to count those little boxes or rely on your interval interpretation? Yeah, I rely on the interval interpretation because I'm not counting those little boxes. We express these intervals in seconds and durations. 12 lead expresses them in milliseconds. I mean, it's really simple to convert milliseconds to seconds, right? So when you use an EKG to determine a cardiac rate and rhythm, certain sampling times required. Is it looking at the same part of the heart, or is it looking at the whole heart at the same time? No. That's why your EKG looks different as it moves on, right? Because your patient moves or they breathe. So the right side of your 12 lead might have a different isoelectric line versus left side of your 12 lead. It looks like crap. You can't tell what's going on because your patient moved. It's because it's sampling. Only one beat from each set each is needed to make an interpretation. So there's 6 positive electrodes yielding 6 chest leads. So there's 4 electrodes in the limbs, which make the machine for another 6 leads, which gives us a total of 10. And then we have augmented leads that gives us 12. each lead provides one positive electrode, and each electrode is a camera in a sense when we're looking at what's going on. So the view is from the positive electrode toward the negative electrode. So we're looking at what the EKG is looking at. Think of it as a camera taking a snapshot directly through it. The portion of the left ventricle that each lead sees is determined by the location of the positive electrode. And different placements of electrode will yield different viewpoints. So here's your types of leads, your limb leads versus your chest leads, and then your augmented leads. So leads V1 and V2 have set our views of the posterior heart wall. So a tall R, ST depression, upright T wave. Said tall R wave and ST depressions are generally hallmarks of a posterior wall MI. Inferior view of the heart. Leads 2, 3, AVF, looking upward from the leg. Think of it as the camera looking directly up, said from the left leg. That's what happens when you look at 2, 3, and AVF when you're in proper placement. So positively on the left electrode or left leg. View of the lateral wall of the heart, said leads 1 in AVL, said sometimes known as a high lateral. Said this is looks at the lateral heart wall. Said looks from the left arm toward the heart. Camera, look at it. Camera looking left arm toward the heart. I don't know if does the looking at the view angle helping. I'm trying to determine how to tweak the. Okay, I've made tweaks to the presentation, trying to determine if it helps illustrate better.
That's helpful.
Okay, good.
I think so. I've seen that description 1,000 times, and I was like, that actually makes more sense than anything I've ever seen before.
I tried something different to try to help illustrate it. I saw it in somebody else's presentation. I'm like, I like that. It worked for me. So,
makes complete sense.
All right,
The
cool.
only question I have, and I probably was just asleep during that time. You said these were positive chest leads, but you said the positive was actually the camera, but you showed the view coming this way, not this way.
On the previous one, right?
Well, on all of them.
We're still in limb leads. So. Maybe. Did I back up? I did, didn't I? So limb leads, looking up from the limb. And you're looking lateral wall. So it leads 1 in AVL. Again, that's a limb lead, augmented. So it's looking that way. And then when you're looking at the actual lateral wall, you're looking at V5 and V6. That's the positive view on the left side, looking straight in from that. So low lateral apical view. So we're looking at the apex and the lateral wall of the heart. So it looks from the left lateral chest leads in. So the view of the entire lateral wall of the heart. So it leads 1, AVL, V5, V6. So you're taking both your limb lead, your augmented lead, and your precordial leads from 2 different perspectives, and you're taking everything all together. So what I'm going to do is I'm going to finish the camera views and the leads, and then we'll take a lunch break. That sound good? It's only going to be a few more minutes, just to clarify that. Anterior leads, said V3, V4. So look at the anterior heart wall. It looks from the left anterior chest. Again, you're looking precordial leads in at the anterior wall of the heart. Septal leads, what leads we're looking at when we talk about the septum? Yeah, you're looking at, so V1 and V2, and you were looking directly at the front of the heart. So again, think of V1, V2. Oh, that good, huh?
Mhm.
So lateral. So think of our color code here. By the way, I am going to email this presentation along with the other ones to everybody that put their email address down on this list. So I always think this chart helps folks, but think of your color coding here. Said your septal leads. Oh, I didn't. Clicked off more than I thought. Before we get into dissecting the ST segment, everybody good with us stopping here for lunch?
Yeah.
Okay. What time are we going to be back, Glenn?
Sometime in February.
Sometime in February, is that what you said?